So those are the needs within the cascade of care for monitoring and testing. We need to understand the epidemiology. We need a system for testing and registration. We need awareness and prevention, and infrastructure for linkage to care and treatment, monitoring of response and compliance, and indeed surveillance, both for incidence, for reinfection, hepatocellular carcinoma, and mortality. And this is the well-known WHO's monitoring and evaluation framework for HBV and HCV, and they have in this framework 10 core indicators. And they have also 17 additional indicators from other programs. What's important is that you identify your epidemic. This is really the most important issue. Before you start developing a program, you need to identify your epidemic. And then you need to establish a system and infrastructure for both testing facilities as well as linkage to care. And thirdly, you need to have a good surveillance system to be able to monitor cases, monitor incidence, reinfection, acute cases, chronic cases, hepatocellular carcinoma, and mortality. So the targets of WHO Global Health Sector Strategy on viral hepatitis is very clear. They have targets to reduce new cases of chronic viral hepatitis B and C infections, and the indicators proposed are cumulated incidence of HBV infection in children 5 years of age, and also incidence of HCV infection. Mortality, reduced deaths due to viral hepatitis B and C, deaths from hepatocellular carcinoma, cirrhosis, chronic liver disease attributable to HBV and HCV infections. Secondly, interventions, expand and enhance services. The targets are Hep B vaccination, give the 3 doses, coverage of 3rd dose of the Hep B vaccine among infants, also prevention of mother-to-child transmission by giving the birth dose of the vaccine within the first 24 hours after birth. And now with the new guidelines, there is going to be also screening of pregnant women as well as treatment of pregnant women if there is need to. Harm reduction, providing sterile needles and syringes for persons who are injecting drugs, and needle syringe distribution, in addition to the safe injection practices. Blood safety, reducing rates of transmission of transfusion-transmitted infections, and the indicators would be blood screening coverage. And finally, with the injection safety, administer injections with safety-engineered devices in and out of the healthcare facilities, and I hope that many countries within the next few years will be having more and more legislations to obligate the use of safety-engineered devices and auto-disabled syringes. And the indicators proposed would be facility-level injection safety. For number 6, viral hepatitis B and C diagnosis, diagnosed persons with chronic Hep B infections, Hep B and C, and the indicators will be people living with HBV and HCV being diagnosed. For the treatment of viral hepatitis B and C, treatment coverage initiation of B and C infections, and viral suppression and cure of hepatitis C, those are the indicators. So what about the data sources that we should use? We should utilize all data sources we have, starting from the biomarker surveys, like demographic health surveys, among others, multiple indicator cluster surveys. These surveys address hepatitis B and C, and they should be used, those data should be used to utilize epidemiological data and generate more data to understand the epidemiology and be able to apply a good strategy for your country. Cancer registry, case reporting for hepatocellular carcinoma and cirrhosis, and there is also an international cancer registry, and I suppose many countries now are joining the international cancer registry. Program data like needle syringe programs, lab infrastructure for testing, clinical patient records of healthcare, lab records, specific surveys for immunization and injection safety, routine surveillance system for acute and chronic HBV and HCV cases, and estimates through mathematical modeling. And you will find the data systems for hepatitis elimination. There are lots of tools on the WHO site and WHO guidelines. This is an example coming from one of the countries that utilized most of its surveys. It's actually Pakistan, and that was presented by WHO. Looking at data from World Health surveys to surveys with data on total household expenditure, even the NCD surveys, multiple indicator cluster surveys, multi-country surveys, integrated household surveys, and many others that could be used to be able to identify the problem. How about the place of modeling in viral hepatitis to generate strategic information? And this is really important because models need data. Once you have a data, you get those data into the models, and then you can validate and use those data to analyze information, interpret evidence, knowledge, consolidate, influence, implement, and see the impact with monitoring and evaluation, and of course with sensitivity analysis to points where we need to. So the first thing we need to do is define our epidemic. And you need to develop based on your epidemic testing strategy. Of course, populations are different in size, and we need to know whether the epidemic is generalized or a focused epidemic. If generalized, you have to embark on a population-based testing, and I'm going to show you an example with Egypt. Focus group, most vulnerable groups should be selected, injecting drug users, prisoners, migrants, even women, children, women in childbearing age, among others, hemodialysis patients, inherited blood disease, and this is called micro-elimination. And eventually the micro-elimination efforts would lead to macro-elimination, and the other way around. Macro-elimination can be broken down into provinces, states, villages, as we've seen today as an example from Egypt. And there has to be an integrated incremental approach. Gradually, we have to integrate the testing within our systems. This is really important, and this is what should happen. Maximizing the functionality of facilities to ensure utilization of facilities, services, especially in resource-limited settings, health system strengthening, the universal health coverage, and make most of the data gathered for other diseases. Those are the core principles of integrated testing of B, C, and HIV that were suggested by the European CDC. With a national testing strategy is critical, and testing in healthcare settings should be normalized. It should be part of the routine. Those carrying out the HIV, HBV, and HCV testing should receive appropriate training and education. And then the testing should be voluntary, accessible to everybody with an informed consent or voluntary, linked to care immediately, and appropriate information should be registered. And those are the guidance covering several European countries, and those are the high-income countries, and you can see diversity between different countries and between the different guidance covering the testing for both hepatitis B and C among different European countries. But it's important that we engage people, and I'm happy today that we had an advocate and we had somebody from the patients, and we have today also in this session somebody representing the patient groups, and it's very important that we engage the people. And this is a shifting paradigm. It's very important. They have a central role in all the building blocks of the healthcare services to improve the outcomes and reach the overall goals. We can find a lot of testing toolkits that are available for training of both healthcare providers and the public. Georgia has testing toolkits that are very nice, that have been developed. CDC, they have testing guidelines. We know that the No-Hep movement with the Finding the Missing Millions movement, they have also testing guidelines, and everybody can refer to it. And there are also flyers and awareness campaigns to encourage testing of the public. And this is really important, and this is one of the things that we've done with our campaign. This is an example of the uptake of testing and linkage to care in Australia that was presented last year at EASL, or this year actually at EASL, showing that the persons who are injecting drugs, they still need support. They are still not compliant enough, and they need more support to uptake the test and to be linked to care. But we have still many challenges. There is lack of data. We need new technologies. Maybe you've heard from Felipe this morning about new technologies. There is also the triplex HIV, HCV, and HBV prospectively is going to be available as a RDT, and FIND is doing some work on this for all three viruses. We need fast-track pre-qualification by WHO for all those new technologies. We need, of course, simplification of algorithms of testing and linkage to care, affordability of diagnostics and strengthening surveillance coupled with vigilant prevention. And it's very important to understand, and governments understand, that saving with affordable diagnostics is a financial investment. It's really important because if you invest in testing of screening of HBV, screening 5.5 billion people, and HCV screening of 6.1 billion people, in addition to treatment, we can avert 4 to 5 million premature deaths and decrease the global mortality by 5%, and 10% will be increased in healthy life years. So finally, I think we need a people-centered health system for hepatitis elimination, planning, proper planning with a strategic planning, including and not excluding all marginalized populations, not stigmatizing people, workforce needed to achieve the elimination. We need financing, budget for provision of testing and treatment. We need a capacity to monitor. Monitoring is really costly and is very difficult to do for disease progression and also for incidence, among others. We need strategies for engaging the marginalized populations. And finally, we need effective surveillance, monitoring of loss to follow up. And I would like to end my presentation with this very nice picture I took in a meeting in Abu Dhabi that I attended last Tuesday on the 19th of November. It was between the Global Institute for Disease Elimination and the Bill Gates Foundation for elimination of rare diseases and eradication of diseases. And in fact, by the end of the day, they collected $2.6 billion for eradication of polio. Although there are 2 pockets of polio in Afghanistan and in Pakistan with very small numbers of patients, but they donated that much. I think we're not doing enough for hepatitis. Thank you.